How to plan corneal allogenic intrastromal ring segments for patients with keratoconus and pellucid marginal degeneration. This is an instructional video for surgeons who are just beginning to undertake the procedure. So importantly, planning for CAIRS is not the same as planning for Kera rings or intacts. You cannot use the previous nomograms. CAIRS works differently to other ring segments. There's a component of epithelial remodeling. This is probably the biggest effect of CAIRS. There's potentially some improved corneal biomechanics, but there isn't a centripetal effect, either that pushing or that pulling effect that is had with certain sized artificial ring segments, such as Kera rings and intacts. So for planning CAIRS, use your anterior sagittal curvature maps. And when we're planning the procedure, remember you get flattening centrally in from where you place the corneal ring segments. So your rings go just peripheral from where you want the cornea to flatten, and the more flattening you want, the bigger the implant you use, but that's bigger vertically typically, so from the anterior to posterior measurement of the corneal donor that you're using. I will cover graft cutting and graft sizing in a separate video. So when you're learning with CAIRS, overdo it, don't underdo it. It's easy to go back into the eye, into the tunnel, to remove a component of the ring, to cut a little bit of the ring off, to manipulate the ring, but it's much harder to add more tissue into the tunnel than it is to remove some. Like any new surgical procedure, be sensible when you start it. Probably don't start with a cornea like this. This is a cornea that would typically do very, very well with a topography guided PTK. So for your first few CAIRS cases, do some more severe corneas. Yes, you can perform a topography guided PTK on a cornea after they've had CAIRS. We do it all the time, but again, that will be in a separate video. So we've got pretty typical keratoconus topography here, and as you can see, the treatment plan here, we go to center the ring segment on the steeper parts of the cornea, looking to get some flattening there to regularize that corneal topography, and these cases tend to do very, very well with CAIRS. So a pretty similar picture here. We want to flatten the 52.4 and the 46.9 axes there. So again, we've focused our ring based on the steeper parts of the cornea to give that flattening. I haven't put post-CAIRS topography in these cases. It's just to demonstrate the location of single ring CAIRS cases. Again, I'll cover how to plan CAIRS when you're going to use two rings, but again, that's a different video. So here's one where I may not use a standard CAIRS ring, so it's steeper inferiorly and a little bit temporally. This is the patient's left eye. So you can see here from the plan, but what I'd probably do over at around the axis with 45.7, so temporally in this patient's eye, I would probably thin the CAIRS segment, make it a little bit thinner, not as wide, not as thick, and that will give less of a flattening effect over that area of the cornea that isn't as steep, but a good flattening effect inferiorly. So a very similar concept here being demonstrated. I've tapered the end of my CAIRS segment so that I get less of a flattening effect towards the end of the CAIRS ring segment and more towards the center of the CAIRS ring segment. I wanted to demonstrate a case here to show that you really can do a segment that's almost 180 degrees if your incisions are opposite each other. This patient had an amazing result from their CAIRS, an enormous flattening and improvement in vision. So you can see I've essentially made the CAIRS segment 180 degrees, extending from one incision to the other. And we can take that concept to the next level in pellucid marginal degeneration. You can use a very long ring segment, but also your incisions don't have to be 180 degrees from each other. Here you can see my incisions are about 90 degrees from each other, and my ring segment is almost 270 degrees. This is often necessary in cases of pellucid marginal degeneration. You do need the correct instrumentation, but you can get some amazing results for pellucid patients without all of the complications of a full thickness corneal graft. I'll have a lot more educational videos and instructional videos for surgeons to come on how to plan CAIRS, including all of the different steps of the procedure.